Hello. Welcome to Reducing Risk, a series of podcasts from Medical Protection created specifically for clinicians in Aotearoa, New Zealand. Reducing Risks looks at key medico-legal issues in our jurisdiction and provides helpful advice and guidance on how to manage those risks. This current series focuses on demystifying the Medical Council standards. So we're going to look at the areas of concern that the Medical Council might have about a doctor and what your responsibility as a clinician might be in those areas. And the three main areas are health, competence, and conduct. And so we'll look at some scenarios and discuss the options that you might consider or you might be obliged to take. Today I'm joined by Amy Creedon from Wharton & Kearney, who are our panel lawyers. Hi, Amy. And also Lucy Gibbard and Sam King, who are my colleagues at Medical Protection. Hi, Sam and Lucy.
Hi, Tim.
Hi, Tim.
Sam and Lucy, you are sitting in the department office first thing on Monday morning. Your colleague John arrives looking a little dishevelled. John's an excellent co-worker. He's dedicated. He's willing to take on those additional responsibilities when the department's short-staffed. He's well liked by his patients and he provides good medical care. But you have noticed at the last couple of department functions that he does seem to be drinking a little more than usual. And at the last function, when you carefully suggested this, he was quite defensive and even, a wee tad aggressive, which is not his usual style. There are rumours that not all is well at home, but John has never talked about this. However, today, when he comes closer, you can clearly smell gin and you notice his behaviour is a little odd. So, quiz time. Do you 1. Assume that he just put on the shirt that had gin spilt on it last night and suggest that he puts on a clean one before the ward round? 2. Ignore it completely because half the department smell of gin on a Monday morning? 3. Take him aside, tell him to get a taxi home and you promise not to mention it to anyone? Or 4. Take some other action, and if so, what? Trick question?
Tim, I'm worried about your department if half the department smells of gin on a Monday morning.
Yes, I would be too. So, Sam and Lucy, what are the principles involved here? And maybe not the details of it, but the kind of things you need to be thinking about in this scenario.
I think if your colleague is perhaps under the influence of alcohol, it might be better for the patients if he doesn't see them.
Perhaps.
So patient safety, I think, is obviously the prime focus here. And I think in the initial instance is about removing him from work and making sure that he isn't a danger to anybody else as a first step. And then I think you need to think about what you need to do following that.
So even if he says, no, I haven't had anything to drink, I'm fine, you're still going to take action?
I think you need to. I think you're compelled to. If you're smelling gin on his breath, then yes.
And I think it's really hard to it's a really difficult situation, to confront a colleague that you've known for a long time and he might be struggling, but still at the end of the day, that patient safety thing is paramount. But I think you just have to be reasonably firm and say, look, you're telling me that you haven't had anything to drink. However, you seem to be impaired and also I can smell gin and therefore I think it's safest for you and for your patients for you not to, and obviously you'd not to be working, but you'd want him also to be having a safe place or way to get home. You wouldn't want him to be driving home, obviously.
And certainly the Medical Council would support that. And in fact, they say that it's important to act promptly, even if your concerns prove later to be unfounded. And provided you've taken action in good faith, as we'll see later, you're not going to be criticised for that, even if it subsequently turns out that actually it was gin that was spilled on the shirt last night and he didn't realise. Yeah,
I think it is when you're talking about a hospital, which is very hierarchical, it would be very difficult. Let's just say you're the registrar or the house officer and it's your consultant, the SMO, who's come in, who's smelling a little bit of alcohol. I think that it would be a very anxious moment for a junior doctor to confront an SMO.
I think you'd go and find another SMO, wouldn't you, and say, I've got concerns, can you assist me? But it's also really difficult because you don't want to be spreading rumours if you haven't got any evidence.
That's right.
It's a fine line, isn't it?
Yeah, and that's why now most organisations have reporting procedures and policies in place to notify concerns or incidents. And so given that hierarchical nature of, say, a hospital, they've got somewhere to go. They don't have to confront the SMO directly, which would be rather intimidating.
Yeah.
Possibly career ending.
Yeah.
And if that happened, Amy, does the organisation have any responsibilities in this circumstance?
Yes, they do. Under the Health Practitioners Competence Assurance Act, there is a mandatory reporting to the council. If an individual has a concern that a doctor may be unable to perform the functions required to practice because of mental or a physical condition. And that would end up with the Health Committee, which we'll touch on later.
So would John be allowed to come back to work tomorrow when he hasn't been drinking?
Yes, he would. Right. He may then be he may receive a notice to report to his clinical director and then within the management or HR, and they will make some inquiries to see if there's a wider issue,
right,
or so forth. And that's when they may talk about the requirement to notify the medical council.
And I guess the health committee, if they had been notified, they may take some immediate steps as well, mightn't they?
Yes, they will. They will definitely put interim measures in place to make sure that doctor is safe. Make sure the public is safe by stopping that doctor practice, even if it's just on an interim basis.
Okay. Let's look at a slightly different scenario then. You're a GP, and thanks to your high standing in the medical community, you've got a number of doctors who come to see you as their GP. Wendy has been your patient for a number of years, and you see her frequently, but her consultations are always appropriate. She makes an appointment to discuss her sleep, which has deteriorated in recent times. She reports that life as a GP has become more stressful, which we understand, and she does ruminate on this at night and just thinks if she got a better sleep, she'd feel much better. You ask about symptoms of depression, and she answers no to everything. So you come up with a plan of management for her sleep, and you suggest that she comes back in a month to discuss. Well, she doesn't come back in a month, but 6 weeks later, she's brought in by her partner for an urgent appointment. It turns out she'd been getting steadily more depressed over a couple of months, and then 3 nights ago, she took a large number of sleeping tablets when her partner was away. And having woken up much later the next day, told her partner what she had done. This time she admits to significant depression symptoms with suicidal ideation. But she begs you not to inform the medical council because she's heard terrible stories of doctors not being able to return to work for months because of the council's actions. You address the clinical issues and ensure that she has time off. What else needs to be done? Sam and Lucy, this is a pretty challenging scenario, really, isn't it? Because I think this meets the mandatory requirement to report, but your patient, to whom you have a very direct responsibility, says, don't do it. What are you going to do?
I think that one thing you need to think about is the therapeutic relationship and trying to guard that. And if you decide that she can't work because, she's not well enough to do so, you're buying yourself some time. You're buying your patient some time in order for the patient to be able to come around to the idea that the medical council must be notified. And then I guess it comes down to who does the notification. Who's better to notify the medical council, the GP or the patient?
So if you've signed her off work and you're assured that she's not working, you don't have to notify on that day. Because actually there's no risk of harm to the public, is there?
No, that's right.
But having said that, if you think there's an ongoing risk, you do have a legal obligation to do that. But generally we try and make sure that the doctor involved is given the opportunity to report themselves. I mean, I think we all agree that the outcomes tend to be better, doesn't it, when the doctor reports themselves rather than somebody else reporting them?
It certainly would give the impression to the health committee that they're taking some responsibility now for what's going on for them, and that's got to be a good starting point. Yep.
Absolutely. It also allows the individual to front foot it and provide their side of the story in the first instance, rather than having to respond to concerns that may not be completely correct, they can front foot it, tell their side of the story, and that's what that becomes the basis of the notification, not by some other third party, and that is beneficial to the individual.
And that whole thing about the time, Wendy's worried about the time off work. It sounds like she might need some time off work anyway, to be honest. But actually sometimes if you can give people some time off work and they can actually start making some therapeutic relationships with counsellors and psychiatrists and things like that, that actually helps them with the health committee, doesn't it?
Absolutely.
So what do you do? Because you know that Wendy's pretty keen on getting back to work. You know that she doesn't have a terribly, realistic idea of how sick she is with her depression. And you say, well, look, I'm going to put you off for 2 weeks. Here's a certificate for 2 weeks. How can you be sure that she's not actually going to sneak back to work after a week? And you believe that she's quite safe and therefore you haven't notified the medical council. Anything else that we should be doing?
Well, you could be checking in with her, but it's onerous, and as GPs you've got a number of other things to be attending to, or having Wendy herself check in, even if it's with the nurse, you've got that point of contact. But it is that, that's relying on good faith in that relationship, and how, if someone has an issue, particularly with addiction, and they may be trying to hide that, so it's hard to tell.
And I don't know that the GP has a right to approach the patient's employer without consent. And so I think the GP can only do what is reasonable under that circumstance.
I often think in those situations using the family is because this time Wendy came in with her partner, and if the partner's actually in that consult and is listening to the conversation that you're saying to, look, Wendy, you're not able to work, you have to stay off work, while we're looking at this notification, and the partner is there, and you actually openly in front of the partner saying, you're not allowed to work, and I'm going to ask your partner that if there is any risk that he thinks you're going to, that he contacts me. That's in front of the patient. At the end of the day, that's not breaching any privacy because he's there. So I kind of think that might be an option to you.
Absolutely, especially if they've agreed to that plan.
Yeah.
Okay, so out of respect for Wendy's, hesitation to have the health committee involved, you've decided not to exercise your mandatory requirement to notify. What happens if things sort of drift? Are we aware of any cases where doctors have been criticised by the medical council for not fulfilling that mandatory requirement under the Act?
Not in my experience, but it's not hard to see a doctor being criticised for not reporting in such circumstances, especially when there's some element of harm to the public or to the patient, him or herself.
Yeah, and so certainly if Wendy ended up going back to work, you weren't aware of it, and then because she's just got no ability to concentrate because of her severe depression makes a fundamental error and a patient really suffers from harm, then you'd certainly think that the medical council would get interested in your actions and not notifying them and ensuring that she didn't work. Yep.
Yeah.
Yep. All right.
And I think we do really try and encourage people to self-notify, and that we try and reassure them that the health process isn't necessarily going to stop them work unless actually that's appropriate.
One of the things I sometimes suggest to doctors who ring with this question is to say, look, I'm not going to notify, but in, today's Tuesday, on Wednesday of next week, I'm just going to give the health committee a ring just to make sure that, you have done what you said you're going to do and have made that notification yourself. So it's really just a check up that it's happened. So it's a kind of a notification without being a notification, if you like, but it gives your patient still the chance to take that responsibility for herself. Wendy does seem to have a pretty dim view of the health committee. Amy, do you think her view is justified?
No, I don't. I have regular interactions with the health committee, and in my experience, they do look to keep the doctor practicing within reason, and they only take interim measures if necessary to protect that public. And it's something that they consider regularly once steps have been taken to reassure them that that doctor's health is back to where it should be and fit to practice.
Okay, good. Well, that's reassuring. Good to hear.
I think, sorry, if I might just have a comment. I'd agree with Amy. The Health Committee are great in my experience in terms of getting doctors back to work. I think the Health Committee, particularly when it comes to mental health issues, they have a process that they follow. And I think that some doctors do find it frustrating because a lot of doctors do want to get back to work for a number of reasons. And because it generally involves independent assessments by psychiatrists, and those things can take time to set up, and you need, letters from your GP, etc., that does take time. And so I wonder whether that's a frustration, and perhaps your patient here, Wendy, might be thinking about that. But overall, I think the Health Committee work very hard to get doctors back into work and as soon as possible. So I think it's a very good process. The only thing I wonder is, like, for example, for Wendy, if she's taking these excessive pills, has she actually been prescribing? Because the Health Committee, things tend to escalate when doctors add professional conduct issues to the mental health issues or whatever health issue that they have. And so that can complicate the process.
Yeah, that's right. The Health Committee will notify the professional standards side of the Medical Council if there are concerns. For example, a doctor has been self-prescribing, and that will invoke its own process separate to the Health Committee's process.
So that will certainly complicate matters for Wendy if that's the case. Yep. All right, any other comments on the health side of the Medical Council? Great, okay. Well, so we've got some mandatory reporting regarding health. Things are maybe a bit more nuanced, perhaps with competence and conduct. So competence concerns can be notified to the Medical Council via a number of channels. When the HDC commences an investigation, the Council is always notified, and it can choose to act immediately or, depending on the findings of the HDC, when the investigation is eventually concluded. The Memorandum of Understanding between the two organisations also provides for the HDC to notify the Medical Council if there have been 3 complaints, and I like to quote, because it's not always followed, of a similar nature in a period of 5 years, even if none of these complaints is upheld by the HDC. And if you look at the data from the Medical Council, nearly 2/3 of the competency notifications come from the HDC. There's also ACC, who, if they decide that the care provided in a treatment injury claim is such that there's a significant risk of recurrence, then the law obliges ACC to report. So this can either be to the Ministry of Health or to the Medical Council. And this is one of the reasons why we often advise members that we'd really like to see those reports that they're writing for ACC if it's concerning their own actions in a treatment injury claim. We don't want doctors to be, if you like, falling on their swords to encourage the claim to be accepted, thereby creating a real problem for themselves. The other cases that we see are notifications from colleagues, and it might often be the clinical director of an organisation or from individuals. Are there any specific areas where there's a mandatory notification about competence?
Yes, there is, Tim. When an employee is dismissed from an organisation or resigns for reasons of incompetence, then the employer is required to notify the Medical Council.
How often do you think does it occur that someone's dismissed just for reasons of incompetence? It seems to us that a lot of those things are very mixed, and there might be a little bit of a competence concern along with some conduct concerns and some all kinds of other things. So,
yes, absolutely. It can be used as a negotiating tool, or maybe that's negotiation is a nice way to put it. But it's used as that carrot and stick approach, I guess, and people will resign without a formal inquiry being made or a finding about incompetence. But with the large organisations, say as the Te Whatu Ora, I think you'll find that they would follow those obligations more than, say, an individual employer who's looking to move someone on.
So that would normally follow from some formal investigation, and there's I think the Clause 42 investigation process is the one that's referred to there. So obviously, if at the end of that investigation the employee is dismissed or resigns because of the competency, then there's a notification is required from the employee. How else does that fit in with the medical council requirements around competency? Is there any other relationship to any?
I think
comment
the
on that?
hospitals, in my experience anyway, the hospitals sometimes use a Clause 42 in order to decide whether to make a notification to council. I think that it's a pretty tough road for a clinician to go through both the Clause 42 investigation at the hospital and then go through the medical council process. And I guess depending on the specific case that we're dealing with, sometimes it's better just to say, let's welcome the performance assessment. And that might shortcut, just to save a bit of time, if you like, and a bit of stress for the doctor.
So just clarifying for me, so a Clause 42 investigation, that's an investigation that the hospital undertakes about someone's competence, is that right? Right.
Under the MECA.
Under the MECA contract, okay.
And normally we would have ASMS or the
Right.
Association of Salaried Medical Specialists involved.
And so normally the
SNO is a
council
member.
don't get involved with that while the 42 is going on, except if the hospital chooses to report them. Is that right?
I think once the medical council are notified, they will automatically begin their process, regardless of whether a 42 is in place or not.
And it's a little bit of a double jeopardy almost, isn't it? Because if a competency inquiry has started and then you choose to resign, the employer is also obliged to report you, even if there hasn't been a finding of incompetence. So actually, once that process starts, you're at real risk of if you resign, you're going to get reported to the medical council. So that's really a tricky situation, isn't it?
I've been involved in cases too where the hospital are going down a Clause 42 road, or they're still in the middle of an investigation, but one of the clinicians has decided off their own initiative to make the notification to council. It just gets very messy, I think, for hospital doctors.
I do also think it's an odd situation, and I often talk about it with the registrars, that if a doctor has a health condition that is affecting their ability to practice, then their colleagues have an obligation to report them. But if that doctor is just completely incompetent, their colleagues have no obligation in general to report them to medical council. It just seems a bit odd, doesn't it?
Yeah, although I often say to members, because obviously, as with all of us, you get members who call in and say, well, I've got concerns about a colleague. And so my advice generally is the stronger your concern about patient safety, you need to act faster and you need to act more decisively. Whereas if you've got general concerns but you're not scared for the next 5 patients that doctor sees, I think you've got a little bit of time to perhaps investigate, do an audit, and then approach the doctor. But if you think, no, I think the next patient that this doctor sees is at risk, then I think that prompts you to act faster. And
So you're saying that even though the colleagues have no legal obligation to their report an incompetent colleague, actually they do have an ethical or a moral duty to do that to ensure the safety of the public.
I think so.
And that's certainly the number one principle that the council seems to apply is the safety of the public is paramount.
Yeah, and
your
that's
actions-
reasonable, isn't it? I think we'll all agree with that.
Yeah, exactly.
And they use that language, you should notify, rather than
Yeah.
mandatory, which was the nuance Tim mentioning. But you can see in that language they are encouraging you to notify, even, and then the medical council make that call about.
So if I do that
doctor.
and it turns out that my colleague is actually competent, am I going to get in trouble?
So long as you acted in good faith, you won't. And in my experience, I've never seen the medical council find that a notifier has acted in bad faith, even though the doctor, and when I've been acting for that doctor, you can see there's some underlying issues, whether they're a personal issue or arising from the work environment, that has sort of been the genesis for the complaint. But I've never seen the council make a finding that notification's been made in bad faith.
Okay.
But inevitably, it's going to create some interesting scenarios at work, isn't it? If you're still working with that colleague.
Yeah.
And it does, doesn't it?
Yeah.
Well, we've seen partnerships break up as a result of this sort of thing. And I'd agree with Amy that, in certain cases you can see that the motivation behind the notification is motivated perhaps by financial competition or, a personality clash. And I think that it's quite disturbing for me to see one doctor notify another doctor to counsel. It's a huge process for anybody to go through, and yet these notifications are made for ulterior motives.
But then we have to have faith that the council process in the end, when that assessment is made, will actually come to the correct conclusion.
And I think, a lot of doctors go through the performance assessment and they come out with a grade 1. In other words, they are practising at an appropriate standard. And I think that silences every voice. Then that might come up, oh no, you're not competent. Well, actually, you've passed your assessment, and so therefore council deem you to be safely practising.
That's a nice little segue on to what happens as a result of these notifications. And we've covered this in some of the other podcasts that we've done, but it might be worthwhile just doing a brief sort of review here. So, Sam, what happens when a notification regarding competence goes into the Medical Council? What's the quick summary of the process from there?
Initially, it goes to the notifications triage team, or the NTT. NTT meet weekly, and so you get a decision from them relatively quickly, thankfully. And they can either choose to take no further action, which, to be honest, doesn't happen a lot of the time. They could determine to have a preliminary competence inquiry, or a PCI, and I think council are using them a little more often, and I think it's a great tool. It's you get a colleague or a peer who comes in and spends a few hours with you, looks through your notes and talks with you. And I'm not aware of any of the members who've gone through a PCI who've actually failed that. I don't know if any of you, the rest of you, have had.
Sadly,
yes.
yes.
So have I.
So if you're going for a PCI, you need me assisting you.
Yeah.
Right.
Yeah, a PCIs are voluntary, so the NTT can't compel you to undergo that process. But usually, the doctors, if you have confidence in them, they will come out okay, and that will be the end of the process. So it does short circuit a 4 to 6 month performance assessment process. Otherwise, which obviously is in the doctor's interest to get that sorted.
And it often seems to be actually a good sign if a PCI is suggested, because it implies that the council wants to be reassured about the competence, but it doesn't feel the evidence in front of them is so bad that they need to immediately go for the next option. Yep.
Well, I mean, to be fair to the Medical Council, they get a notification of concerns. They then get the doctor's response, and it's hard on the papers alone to actually make a determination about the competence issue. And having a PCI gives them an independent report by a vocationally registered practitioner that this doctor's practice there are no concerns, or there may be some, but they're minor. And it's on that basis they can make a decision about whether or not further action is required. And in this case, they wouldn't. So you can see why it is useful and should be and is being used more frequently.
Yeah. So you mentioned the PAC, the Performance Assessment Committee. So, Lucy, what's in a nutshell, what does that involve?
What does a PAC involve? Look, generally what happens with a PAC is that it's made up of 3 members. 2 of them will be peers in the same speciality as you, or the same vocational registration as the doctor involved. So if it's an obstetrician, there will be 2 obstetricians. If it's a general practitioner, there will be 2 general practitioners. And then there's a lay member as well. So it's 3 people. Generally, they will come to your place of work, be that a hospital or a practice, and they will go through several processes. They'll talk to members of staff, they'll look at notes, and they will often actually sit down with a practitioner and talk through clinical issues with them. They might sit in on consultations, or with a surgeon, they might actually sit in on surgeries. And generally that process might take a couple of days. So it's a really involved process whereby they look at all aspects of the functioning of that practitioner in their work and their competency on a number of areas, not just clinical competency. It's often about their interactions with peers. It can be often about their records. And if we look at the things that people often trip up on, it often is those things. The communication skills and the notes tend to be high on the list of the thing that they get criticised for. So at the end of that 2 days, the committee go away and they come back sometime later with a report. And in that report, they give the doctor a grade, which is either 1, 2 or 3. 1 means, no, this person's absolutely great, competent to practice in their vocational sphere. We haven't got any specific concerns. 2, yes, they're okay to practice, but there are some areas that they need to be upskilled on, and those doctors will often be given educational programs. So they might be given a program over a year of some areas where they're required to upskill. And then if you get a grade 3, it basically means that they consider that you're not able to practice.
And sometimes they take even more precipitous action. I had one case where after the first day of the pack, I was rung by the council to say that this doctor must not ever see any patient ever again, and could I please help ensure that that didn't happen?
Oh my goodness!
Yeah.
Wow,
He was.
I've never had that.
No, that was it was a very sad case, but they were exceedingly concerned about how he
I have to
performed
say,
in the pack.
I think often it's a 2. You know, I think very, very commonly they find something that could be improved, and I think with lots of us, if I had a pack come and look at me, they might find something I could improve. But so 2s are kind of common. 1s, yeah, we see some 1s. Not so many 3s, I would say.
Yeah, no, I'd agree. Not many 3s.
But a 3, obviously, a lot is going to be required of that doctor to get themselves up to standard if they...
Well, they're not allowed to practice after a 3, is
They
that right?
can, and they can, not in all, but some situations. But council, I've got one at the moment, they'll issue a risk of harm notice, and that goes to various agencies, HTC, ACC, I believe. And it stays on that doctor's record until steps are taken. The council can be satisfied that the doctor meets required standard of competence, and that's usually through recertification, re-education.
Starting again.
That's right.
And they're always closely supervised,
And they're
aren't
closely supervised, yeah.
Great. Okay. So look, that's 2 of the 3 arms, and the third one that we're going to discuss today is conduct. So the Council has a number of statements and guidance papers on conduct and professionalism. And one critical point to remember is that the Medical Council considers not just your behaviour when you're working, but actually at any time of your life while you're a registered practitioner. So it leaves a wide range of possibilities that the Council may want to get involved with. Now, we won't cover the topic of sex because Lucy wants to devote a full podcast to that, and Sam's going to be addressing the issues around treating yourself and those close to you. So what other activities might result in a notification to the Council about conduct, and what responsibility do we have as clinicians to notify regarding our colleagues' activities? So how does the Council define unprofessional behaviour? Now, this includes inappropriate behaviour as well as one-off incidents that may be disruptive. The inappropriate behaviour or incident may apply to interactions with patients, with other healthcare professionals and colleagues, or outside of work. And why is the Council concerned about unprofessional behaviour? Well, the view is that unprofessional behaviour, in whatever setting it might be, has got wide-ranging implications beyond just that individual doctor who acts unprofessionally. It's certainly been shown to have a significant impact on patient care. It has a significant impact on interactions with other health professionals and colleagues, and it can also affect how the public perceives the medical profession. And I think that's quite an important point for the Medical Council. They really are concerned about the public perception of doctors and the medical profession. And the wording is that you should contact the Medical Council when unprofessional behaviour by a doctor poses a risk of harm to the public. So it's a pretty wide brief. The wording again is should rather than must, but there's certainly a risk if you witness conduct or behaviour that's very unprofessional and don't take action as a result. it can involve activities, of course, that are not patient-related. And I was involved with a case where a doctor was looking to employ a new member of staff. And in the process, they were accused of inappropriate, though not sexual, touching, and other actions which were alleged to be not appropriate. There was a police case, but it was dropped. And after some effort, the Medical Council was finally concluded with no referral to a PCC. Despite, however, no patients being involved, there did require, well, it's called a voluntary undertaking that the council suggests, but the stick is that unless you sign a voluntary undertaking, there may be conditions placed on your practice, and those conditions get notified publicly, whereas voluntary undertakings don't. And in this case, the doctor was not able to see any female patients in person without a chaperone. We could actually probably do a whole podcast on voluntary undertakings and chaperones, as this is an area of increasing concern for us. So, professional behaviour notifications. Sam, have there been any particular themes that have appeared at the Medical Council in the last couple of years?
I think with COVID and vaccinations and alternative treatments that some patients and doctors are interested in, that certainly generated quite a few cases with Medical Council. And I think that the Medical Council, it's been very interesting to see the view that Medical Council have taken around professional conduct and even what is the practice of medicine and how far the Medical Council view their reach in terms of what we do as doctors in our life.
The council certainly do seem to have taken quite a hard line, and as a non-lawyer, I do wonder about where does freedom of speech come into this whole process. Have you got any thoughts around the freedom of speech versus requirements of the Medical Council, Amy? Sorry to dump this on you without any warning.
There is a tension, without a doubt, and we have cases just about to go before the tribunal, the health practitioners disciplinary tribunal on that very point. Also in the legal profession as well, lawyers and taking stances on vaccinations and so forth. The Medical Council has taken a robust review on that. Hence, they have brought disciplinary charges, and I guess we will wait and see the outcome of these cases in the next probably six months.
Right, yeah. And I wonder if it's because of this concern about how the public perceives the profession that they've decided that this is something that they really need to put a firm line in the sand about and get it quite clear. It's certainly, COVID has raised some issues which hadn't really been obvious before, but may well be factors in the future.
I think council have a concern for public safety and the influence on the public, specifically related to COVID. And, you know, if we've got clinicians who are actively discouraging patients from being vaccinated, for example, that does have a public safety factor to it. So it's not a straightforward topic, unfortunately. It's really complicated. And I guess all of us have our own views around vaccination and that kind of thing. But certainly that's, in terms of unprofessional behaviour, that's been something that's been a bit of a theme.
Yeah. Though to be fair to council, they did put out their views very early in the process regarding vaccination. And so I don't think any doctors could pretend that they were unaware of how the council would view actions that went fundamentally against what the council had suggested was appropriate. So, yeah. All right. COVID's not the only thing that could be reported to the notified to the council. Lucy, what are the other kind of things that a PCC might be established for?
Well, I think some of the commonest ones we see are for prescribing for yourself and those close to you. That is an oldie but a goodie, and I think we are going to have a podcast on that coming up, so I won't go into that too much. Unprofessional behaviour, I think things like drink driving, scope of practice, inappropriate or inadequate records, misrepresentation or sexual boundary notifications, and convictions related to alcohol. So there are lots of areas where they may be issues outside your professional life. If the council become aware of them, they may choose to form a professional conduct committee and look into that further.
And the numbers, I think in the 2022 year, out of around 250 notifications to the council regarding conduct, they ended up holding, I think, around 30-odd professional conduct committees. So most of them don't end up in a professional conduct committee, but certainly those more serious ones do. Amy, can you sort of briefly describe what that process is for the professional conduct committee, who does it and what happens?
So like with the performance assessment committee, the PCC comprises of two of your peers, so in the same vocational scope of practice. And usually council from its pool can accommodate that. And if they can't, there will at least be one. And then there's a lay member. And they then get asked to investigate a particular, so that sets the scope of the investigation. The first process the PCC will go through is what they call information gathering stage. And that's to, exactly what it says, to gather information on the complaint. They will interview people, they will request medical records, for prescribing cases. They will often get records of that doctor's prescribing from the Ministry of Health. They have the power to compel any information that they think is relevant, so they have pretty wide powers there. They then, once they have that information, they provide that to the doctor. They're required to provide it to the doctor, and that doctor can review it. Then they're also required to give that doctor a chance to provide a further written submission and or meet with the PCC in person. And once those processes have happened, they then can make a determination.
And do doctors always have to appear before the
Doctors, it's not, they don't have to appear. It's not mandatory. They cannot be made to appear. Again, it is case-by-case basis whether or not we would advise doctors to appear. We found more recently with the flux of the self-prescribing cases and prescribing to those close to you, actually meeting with the PCC has had a better outcome than not. There are definitely risks in meeting with a PCC. If a disciplinary charge is looking likely, and we often advise doctors to keep their powder dry, so to speak, and wait for the charge.
So, final thoughts on notifications to the Medical Council, health, conduct, competence, any final thoughts?
One thing I would strongly recommend is that members get in touch with their indemnifier clinicians. Contact your indemnifier early on before you've made any response to your regulator. At MPS, we deal with this sort of thing on a regular basis. We've got a big team of lawyers with huge experience in dealing with the regulator. And so we understand how to respond, the processes, etc., whereas for individual members without getting any advice, it tends to be, understandably very emotional, and that can often lead to responses that aren't necessarily helpful.
I definitely agree with that. I think getting help. But also, if you're thinking about whether or not you should be notifying a colleague, I think before doing that, seeking advice is also, that is another point at which to consider your options and, talking either to an indemnifier or to somebody else. I think we want to make it clear we don't want people talking about their colleagues behind their backs and making decisions without them. But I think seeking advice, if you're thinking about making a notification, and your indemnifier is sometimes a really good person to to have a conversation with there. Obviously, medical protection, we don't assist with making notifications. We are very much here for defence. But we often talk through the ethical and legal implications of these situations. So it's a common thing for us to talk to our members about.
Amy, final thoughts?
Final thoughts. I entirely agree with what Sam and Lucy have just said about getting help. It is there. It's so easy to access with medical protection. I make sure that you seek advice from your indemnifier, not from the actual regulator. That would be my final comment, because sometimes in doing so, score an own goal, and then you are then the subject. You're now the subject of a council process, which you have to go through. So you're looking to contact MPS, not the medical council.
And I think too that, anytime any of us get a letter from our regulator, it's a big deal. And but you will get through it. And it's possibly not as hard as you anticipate it's going to be. And it doesn't mean you can't go on to have a fruitful career afterwards. But the main thing would be, if you get the help that you need in order to be able to get through it, then it'll be much easier.
I also think the other thing is that the medical council is there for a reason, and it's not, I know they're wanting to be educative, supportive and all the rest, but actually they're there to protect the public. That is the bottom line, and that's what their purpose is, to make sure that the clinicians and the doctors out there are actually healthy enough and are well enough to provide that care, competent enough and behaving professionally enough. And I kind of think we all want to be part of a profession that upholds those standards. So I think, we do have to look at it from that point of view as well, that they're there for a good reason.
And the final plea I would make is that the council expects all doctors to have read and to follow the statements that are published. And so ignorance of the statements is not going to be a very good defence. And there are a number of ethical and, as we've seen, some compulsory requirements on us relating to the acts. And I would suggest that following up from this podcast, you might want to go and have a look on the website and just review those statements so that you're quite clear in your mind about what they involve.
Yeah, and I think we are going to be going through quite a few of the medical council statements over the next few weeks with our podcast. So hopefully you just keep on listening.
Thank you very much, everyone, for joining me today. Thank you to Amy, Lucy and Sam.
Thanks, Tim.
And I hope you have enjoyed listening to this podcast, and I hope it's been helpful for you. We look forward to catching up with you in our next podcast. And if you like these medical protection podcasts, please subscribe and leave a review. And if you would like a podcast on a specific topic, we would be really pleased to hear from you. And you could email your suggestions into nzpodcasts@medicalprotection.org. Thank you. Goodbye.